three walls are mobile. Upper wall does not go up, but lower wall diaphragm goes down. Anterior chest wall moves in front in postural movement. Posterior wall does not move. Lateral wall moves outwards by bucket angle movement. Mediastinum does not move. So three mobile walls, anterior, lateral and inferior. Oblique fissure ensures that both the principal lobes of both the lungs are in contact with all the three mobile walls. If this was sagittal suture, medial lobe of lung could not grow laterally and medially does not move. If it was a horizontal fissure, lower lobe will move in the diaphragm, upper lobe will not be aerated. And if it was a coronal fissure, anterior and posterior lobes, anterior lobe will move ahead with pump handle, posterior lobe will not move. So you have to make sure that both the principal lobes of the lung are in contact with all the three mobile walls. That's why the fissure is oblique. How many bronchopulmonary segments you say? 10 in each lung or 10 in the right lung and 7, 8, 9, 10. In the left lung, some people believe there are 8 segments. Some others believe there are 9 segments. And there are still others who believe there are 10 segments. We follow Gray's anatomy, we say 10 segments. The segments have a sequence also. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Apical, posterior, anterior, lateral, medial. We are talking about the right lung, upper and middle lobe. Above the oblique fissure there are 5 segments. Apical, posterior, anterior, lateral, medial. Remember as a palm, P-A-L, palm. And the lower lobe has got the same 5 segments, apical, but medial, anterior, lateral, posterior. Apical, medial, lateral, anterior, posterior. A palm, a palm. Okay? But you can't give the 2 segments the same name. So all the lower lobe, you add a suffix of basal. Apical basal, medial basal, lateral anterior basal, lateral basal and posterior basal. Okay? But apical basal, they are opposites of each other. How can apical be basal? So apical basal sounded a little odd. So they changed the name to superior. There are no superior lobe segments so far. We just call that apical basal segment. Segment number 6 as superior. Some people also call it as dorsal. When you are bedridden, supine, fluids accumulate in the segment number 6. Segment number 6 is the most dependent segment of the lung in supine position. Okay? That's why bronchopneumonia accumulates there. Next slide. The definition of postural drainage is positioning the patient with an involved lung segment such that gravity has maximal effect of facilitating the drainage of bronchopulmonary secretion from the tracheobronchial. The alternative to this is putting in a tube and sucking out the secretion. Putting a tube into the segment, tertiary bronchus, and sucking out It's very far more cumbersome. This is far easy. Just position the patient so gravity will assist. Normally, secretions are being beaten out by the cilia. Cilia normally beat out. But in a diseased person, either the secretion is too much or the cilia are diseased, they can't pump out as much as they should, and therefore fluids accumulate. So that has to be drained. That's what is called as postural drainage. Remember, if you keep the secretions where they are, they will get infected and the whole lung will get affected. If you drain out the secretion, which are accumulated. That's why postural drainage. Mechanism. During erect position, only the segment of the right upper lobe and left upper lobe, excluding the lingula, receive gravitation. Then upper part, right? The upper part will gravitate down, normal, easy for them. But middle lobe of the right lung, lingular lobe of the left lung, lower lobe segment of both the lungs are draining against gravity. So, in such a case, the mucociliary mechanism is compromised, then you have to position the patient in such a manner. So, how will you position? They have split the hair further. We are talking about the first segment, apical segment. Apical segment has got an anterior part, apical segment has got a posterior part. If the apical segment anterior part is infected, you sit back, slightly recline backwards so that the anterior segment can drain downwards. Whereas if it is affecting the apical segment posterior part, then you sit and bend forwards so that the posterior segment can drain. Is it clear? Apical segment usually does not have accumulation of secretion, because it's naturally assisted by gravity. But apical segment is most susceptible to tuberculosis because apical segment has got maximum oxygen, minimum blood supply. So tubercle bacteria is such that it requires continuous oxygen, and WBC should not come and fight it. So it finds that the apical segment is the best. And when tuberculosis affects the upper segment, then there will be secretions. And for that you need to know whether they are in front or back, which can be easily detected by an MRI or a CT scan. Where are the secretions? And then you position the patient in such a manner that it facilitates them. And if you find that they are perfectly apical, then you can just make the person sit erect. So it will drain both the sides. Now let us assume if there is an anterior segment involvement. When the anterior segment is involvement, anterior should be above, posterior should be below, which means you lie supine. That will automatically drain the anterior segment. Is it clear? Now, but in supine position, if you lie, we have discussed a little earlier, which segment fluid accumulates? Segment 6, that is the dorsal or superior segment. So if the accumulation is in segment 6, you place it in perfect prone position. Because in supine the 6th segment was gravity dependent. In prone position they will become above accessible to gravity. So anterior segment of the upper lobe is lying perfectly supine, and apical segment of the lower lobe lying perfectly prone. What about posterior segment? If the right posterior segment is involved, you lie on the left side with 3/4 prone. Instead of supine, instead of full prone, you lie 3/4 prone. That means he is almost becoming prone, but not fully. This will drain the right posterior segment. Remember, upper lobe of the right lung has a posterior segment, upper lobe of the left lung also has a posterior segment. But these two posterior segments are not symmetrical to each other. That is why when the left posterior segment is involved, you would have thought here it was lying in the left lateral with 3/4 prone, it should have been right lateral with 3/4 prone. Right lateral with 3/4 prone is there, but head should be higher. So that bed is tilted in such a manner. Why? Because the apical segment of the left lobe, posterior segment of the left lobe, is more superior than the posterior segment of the right lobe. So if it is already more superior, you have to facilitate that. Instead of lying on a flat bed, make the head slightly raised up. It is more superior, gravity will assist. Is it clear? Should I repeat the 3 segments again? Apical segment sit erect, but apical anterior sit reclined. Apical posterior sit bending forwards. So this is apical segment. Which part is important? Next one, anterior segment, lie fully supine. Posterior segment of the right side, 3/4 prone. Now which side you should be bent? You have to keep that lung above the carina. So obviously if you lie on the right side, that lung will be below the carina. So you lie on the left side, with 3/4 prone, because you want that posterior segment to be above. Same is the case with the posterior segment of left side. But because of the asymmetry of the two, you don't lie right lateral 3/4 prone on a flat bed. You lie 3/4 prone on an inclined bed with the head above. And you already added one more. You already drained the 6th segment because it's most dependent in supine. The drainage is full prone. Now middle lobe. The patient is tilted or propped at an angle required. Each position consists of placing the target lung superior to carina. What is carina? Tracheal bifurcation. Tracheal bifurcation is called carina. You have to make sure that that segment concerned is superior to carina. Once it reaches the carina, then trachea, larynx, oropharynx, oral cavity, and you can spit it out. This position of the tilting, so far there is not much of tilt. You will see lower lung requires a lot of tilting. This tilting should be held for 3 to 15 minutes. And then, if required, you have to do chest percussion. Tap the chest. Then the secretion will loosen. And the secretion is too tight, it will not drain out gravitationally. You have to tap the chest, and the secretion will get loosened. Right middle lobe. You have to lie left lateral with the foot end raised by 12 inches. Right middle lobe, you will lie on the left lateral side with the foot end raised by 12 inches. This is middle lobe of right lung. And both the segments. Middle lobe. And on the left lingular lobe is corresponding to, you lie on the left side with partially, you lie on the right side with partially. So this is called as quarter prone. So you lie quarter prone for the middle lobe of the right lung, or lingular lobe of the right, of the left lung. So first earlier we spoken about bending forward, backward, fully supine, fully bone, 3/4 floor. Here it is quarter floor. For the middle lobe of right leg, you lie on the left side. Lingular lobe of the left leg, you lie on the right side. With quarter floor. But foot end raised by 12 inches. So this is all covers the upper and middle lobe. Now the lower lobe. We have already discussed one segment of lower lobe, and that was the superior segment, where you lie on a horizontal plane but fully prone. Of course, you have to make sure that you don't smother a space on the pillow. Face can a little here and there. Availability. So here, anterior segment of the lower lobe, raise the foot end by 18 inches. So for the middle lobe and lingular lobe, you raise the foot end by 12 inches. Here you have to raise the mid by 18 inches. And because it's the anterior segment, you have to lie supine. The anterior is most in front. And then automatically gravitate downwards. Okay? What about posterior segment? The reverse of anterior segment. Lie fully prone, but with the foot end raised by 18 inches. Now, how will you get? We have seen that bed which is there in the ICUs and other places, which can tilt this side or that side. I'm sure there is no bed which tilts for 18 inches on one side. 8, 10, 12 inches, okay, but 18 inches, 1.5 foot, that much slope, there is no bed. So what is that? At least in India, you don't have the facility to get a postural bed for each and every patient. So what they do is, if the lower lobe is involved, the bed of the patient is 18 inches above the ground. He keeps the foot on the bed and the head on the floor. That is 18 inches up. And tilt in whichever direction you want, that can be done. Is it clear? Remember that bronchiectasis is a disease where every morning the patient drains 500 ml of mucus. 500 ml, one mug full. So if you don't facilitate that drainage, it will remain in the lungs itself. It will cause infection and a lot of other complications. Right? So here it was anterior segment of lower lobe, supine. Posterior segment of lower lobe, prone, but foot end raised 18 inches. Now, right lateral and left lateral segment of the lower lobe. 18 inches is for common for lower lobe. Right lateral you lie on the left side. Left lateral you lie on the right side. Half prone. So we are seeing a quarter prone, we are seeing half prone, we are seeing 3/4 prone, and we are seeing full prone also. This is half prone. Whatever is draining the right lateral segment, the same position also drains the left medial segment of the lower lobe. Whatever drains the right lateral segment of the right lobe, same position will drain the left lobe medial segment of lower lobe. And same is the case with the left lateral segment. Left lateral segment of the left lung and the right medial segment of the right lung. Medial basal, lateral basal. Same position. And finally, next. We have already seen the abdomen. Who needs postural? First and foremost should have been decrease breath sounds or crackles or rhonchi suggesting of secretion there. This is examination. Take a stethoscope and auscultate lung field. If you see musical note or crackles, decreased breath sound, which means accumulation is there. But nowadays, people hardly auscultate. X-ray निकालो पहले, And then you look at the radiogram, either it shows collapse or not, which is called as atelectasis, or mucus plugging. Mucus, is it M-U-C-U-S or M-U-C-O-U-S? The mucus as a noun is M-U-C-U-S. That is the mucus, the phlegm, what we see is M-U-C-U-S. The gland which produces mucus gland, that is mucus is an adjective to the gland, that is M-U-C-O-U-S. You don't say American British. Here it is, both words are accepted. Both the languages, both are different meaning. Mucus gland producing mucus will be M-U-C-O-U-S gland producing M-U-C-U-S. And then after you've seen that, you do a pulmonary function test. This will tell you how much is the affection. It's a spirometry is a procedure where you ask the person to blow into that machine and then you detect with what force that you are pushing. If you have got already COPD, chronic obstructive pulmonary disease, force with which the expiration will take place will be lesser. And they also check the inspiration. Deterioration in arterial blood gas values or oxygen saturation. Deterioration in arterial blood gas value, which means you need to know the basal value. Then you can say deteriorated. The oxygen saturation as detected by an instrument which is put on the index finger and the nail bed will tell you what is the oxygen saturation in your blood. The normal oxygen saturation is 100%. If the saturation comes down to 91-90, you are said to be mildly hypoxic, not hypoxic. If the saturation comes to less than 60, you are severely hypoxic. 80-70 is missing. 80-70 is called as the golden period. Physically, if you look at the person, he will appear mildly hypoxic. A little extra breathing. Same with 90. That's why it's important. And moderate hypoxia will go in that golden phase where symptoms are not bad, but hypoxia is bad. 60-70. But you have to know what was the initial oxygen saturation of the person in normal states, which we assume is 100%. It's not always the case. When I check my oxygen saturation because of muscle involvement, my normal oxygen saturation is 95. If I reach 91-90, it is not hypoxia at all. Because, as you said, 100 is the saturation, 91-90 is mildly hypoxia. 95 is the baseline, 85 will be mildly hypoxia. Are you getting the point? So, blanket assuming everybody will be 100% oxygen saturation may give you a wrong diagnosis of who is hypoxic, who is not. So look at the person, examine how is he breathing, is he having forceful breathing, then he is hypoxic. So that's why the word deterioration of arterial blood gas. You should know the baseline level and you should know that whether it is deterioration. So this is good about postural drainage. Some exceptions where you cannot do postural drainage. Right? Infants in NICU. Infants in NICU have got various tubes attached to them. If you start doing head down, head up and all those things, the tubes will get displaced. Infants in NICU are drained by a bronchoscopic tube which will suck out the secretion. Anyway, they can't cough out that effectively. So, see, all these thing are reaching the carina. After that you do cough it out. But they do not have the power to cough out also. You have to actually drain the secretion, the tube which is inserted into the lung. Head injuries. Head injuries, stroke, hemiplegics, all those things. The head will be having a lot of fluid in it, and edema of the brain. Now further you raise the leg, 18 inches up, more and more blood and fluid will accumulate in the head and cause more problems about whatever was existing. So you are worsening the patient than what he was. So head injury, and wherever there is cerebral edema, including cardiovascular, including cerebrovascular accidents, all those things you do not do chest physiotherapy. Severe hypertension and other cardiac problems like aortic aneurysm, arrhythmias of the heart, you don't do because when you raise the lower leg, that adds more volume of blood from the lower leg to the heart. The load on the heart further increases. It's already hypertensive, it's already having some arrhythmia, adding extra load, you are worsening the condition. Hiatus hernia, what is hiatus hernia? Where the esophagus, which normally passes through the esophageal opening of diaphragm into the stomach. In the stomach and esophagus herniate up into the thorax. By making head high, you are facilitating hiatus hernia. You are worsening the hiatus hernia. So, esophageal opening of diaphragm is already loose, which is causing the stomach to herniate into the thorax. Making head high, head low. Eye operation, that is very important. Any eye operation, there is always some edema in the eye region. You want to facilitate that edema should go away. You make leg high, head low, you are going to worsen the condition. So these are the incidences where you should not do postural drainage. Any questions? Can we stop here?
Yes.